And you brought your own coffee with your own name on it. Now I am impressed.
So I stayed up till like 1:30 in the morning putting together an IKEA bed for my wife. So, and then woke up at 6, So I got some brownie points, but have a big cup of coffee.
Are you serious?
Oh yeah, we got 5 of her female relatives coming in, so it's like all hands on deck. If I had 5 brothers coming in, I would not clean up my house, but shall we say my house has been cleaned.
Those are the 3 of the worst words somebody says at IKEA, some assembly required.
Yes.
Senator, welcome. In all seriousness, and this is a serious conversation, we are here because of our interest and concern about mental health. And I wonder at the top line if you could kind of address where Congress is, because you have co-authored a series of bills addressing the issue. I know the reauthorization is up again, possibly later this year. But where is the debate right now?
Let me give a little context. We have come so far since I've been in the Senate. Not necessarily due to me, but it's just what has been driving this is the fact that there is pent up mental health needs across our nation. There is a recognition. As a sheriff from my home state, Greg Champagne, past and a future president of the National Sheriff's Association, there are more people in his parish who are with mental health issues who are incarcerated than who are receiving the treatment they need to receive. And he said the biggest mental health treatment center in my parish, in our state, are jails. Now, that's true across the nation. So beginning there, in 2016, Chris Murphy and I collaborated to pass the Mental Health Reform Bill of 2016. It put some good stuff in. Mm-hmm. But you come back 6 years later and you think, that's not how we thought it would be implemented. And this is not really consistent with the vision that we had. So we're doing a reauthorization of it this year. As a part of the terrible incident in Uvalde, there was legislation passed there. So we have the reauthorization of 2016, the 2022 reauthorization of the mental health bill. We had the Uvalde response, which had a huge amount of mental health things addressing. And then we're also working on something through the Finance Committee that would more directly impact Medicaid, et cetera. So, to paraphrase Martin Luther King, because I can't speak as eloquently as he, we're not where we want to be. We're not where we ought to be. But praise God, we're not where we once were. He put it a little bit better than I did. But the point being, we've made great progress. Mm-hmm. We got a long way to go, but we've at least made great progress.
But it is still a crisis that is growing. Why? What are we missing?
Well, I think what we're missing is COVID was incredible in terms of the sense of isolation that it created. I have a family and et cetera, so I'm not a person who's by himself all the time. Except I was up here, for like 2 weeks straight, and I realized I had not physically touched another person. It's kind of, normally you shake hands, you give a hug. We're from South Louisiana, so you kiss each other on the cheek, you bump shoulders. I went 2 weeks without physically touching somebody. There are others with far greater experience than that. And there are others who probably kind of want to touch people a little bit more than that. So I think that sense of isolation was incredible. And I'd be remiss if I was not mentioning veterans. We've had a suicide rate among veterans that has been way too high. Mm-hmm. Now, there's been some good news on that, by the way. That has recently fallen almost 10% relative to 2018. And I say that because we know that intervention works. We don't have to be fatalistic that this is going to happen no matter what we do. We can look at our veterans and say, oh my gosh, we just had a 10% decline. So we know we can put in programs that make an impact upon those who have issues with mental health.
But this is going to cost money, and members of your party continue to talk about a $30 trillion debt. Do you have any concern that there would be some of your colleagues that say, enough's enough, we can't spend more money on this and other issues?
You've got to prove value. If all you're doing is throwing good money after bad, we should all, regardless of party, object to that. Period, end of story. If you can make a case, no. By doing this particular program, we have, or among these programs, we've decreased suicide rate among veterans by 9.7%. That we have reduced hospitalizations among those with serious mental illness by X%. Then my gosh, you're going to build a case that people, regardless of party, are going to support. I will say, what did Ronald Reagan say? There's nothing so permanent as a temporary federal program. So the point being that there should be skepticism across the federal government because so many of the programs don't work. But if you have one that does work, I can tell you the people in my party are going to be for it.
So what's working? Because one aspect of this report, the numbers are compelling. Tens of thousands of lives saved over a 4-year period, and hundreds of billions of dollars would have been saved as well had we done more.
Well, so had we done more? Now, this is an ecosystem. It isn't that you just kind of wave a wand and all of a sudden you have an adolescent psychiatrist who's in small town USA. So of course if we had done more, but do you actually have the physical, the social capital infrastructure by which to do more? Right now, I can tell you that most sheriffs would tell you that if there is somebody who is at risk of suicide, there's not the social worker that's going to go with the sheriff and sit with them. It's going to be a deputy. And the deputy's going to be in the ER. And ERs are still very crowded with those for whom there is no placement should they need hospitalization. So I think we need to put this into context. We're not where we ought to be. We're not where we want to be. But praise God, we're not where we once were. So let's just speak a little bit about what we've done that to address your concern. In the response to Uvalde, there was the amplification, if you will, the nationwide spread of a program which was in 9 states, in which mental health services were embedded into community health centers. Roy Blunt told me, and Missouri is a big rural state, Roy Blunt told me that everyone in Missouri is within an hour and a half of whatever mental health services she or he needs. And they would go to a rural health clinic, federally qualified health center. They embed mental health services. So now if you have somebody at suicide risk or somebody with serious mental illness, the psychiatrist will bring that person to the federally qualified health center, which now has mental health services embedded. So under Uvalde, we have provided funding, with strong Republican support, by the way, to make that program not just in 9 states, but in 50 states plus Washington, D.C.
Let's move from the money debate to the policy debate, because we can relate to the issue growing up in which mental health issues were shunned, you put it aside, you didn't talk about it. We are talking about it much more now. And I'm curious from your standpoint as a member of the HELP committee, where that debate is in Congress, not financially, but just in terms of the issue itself, the awareness of mental health and the inequities in mental health.
Everybody watching here deserves some credit. Because everybody watching cares enough to be watching you and me, Steve. But it took advocacy. We live in a representative democracy. And in a representative democracy, it is advocates who actually make a difference. Now, on the other hand, it's kind of an easy sell. Everybody in any audience I ever speak to has either a family member or a friend or maybe somebody they went to high school with serious mental illness. You add addiction, boy, you really get everybody. And so you're right. For the longest, people did not speak of that. But the tragedy just presses upon you. And so the degree to which people can relate to that wonderful, beautiful girl that she went to high school with, who was later found 30 years later dead beneath the overpass. And you found out that her trail was one of, after a first episode of serious mental illness, one of serial decline. Or the nephew or the niece. Or I could keep going. That just presses upon people's understanding And with the advocates promoting that understanding, we have been able to make change.
So that change comes about also because of a federal-state partnership. What's working in Louisiana? What's working in the states? What lessons can we apply across the country? And a local partnership as well.
Yeah, so you're right. The federal government kind of pushes money down, but unless there is state and local leadership, it's like rain falling on concrete. It just rolls off and it dries, and it's as if nothing happened. So there's got to be that leadership. So one thing that we, after the Mental Health Bill of 2016, that we had promoted was something based upon a Maine experience called, I think it's the RAISE or the RISE. I'm looking at RAISE. I'm looking at my staff who's mouthing to me, RAISE. And what they found in this Maine, I think NIH funded, was that if you took someone first, what we all know is that oftentimes the first episode of serious mental illness is sometime between age 15 and 25. Now, what they found in that Maine experience is that if you give that young person the wraparound services he or she needs, you can return them to wholeness, and that first episode is their last episode. And when they're 50 or 60, it is a distant memory. It is not a life-defining experience. So we have put forward money in the Mental Health Reform Bill of 2016 that would attempt to, through SAMHSA, that would attempt to take that and broaden the applicability, the accessibility of that program. So I go back home and doing a little follow-up, and it takes a few years to get it enrolled, but New Orleans had 4 kids enrolled, and Baton Rouge had 5 or 6, and Shreveport was about to start a program. I'm thinking, well, that's not what we wanted to do. We thought it would have much greater reach than that. So as it turns out, they're using SAMHSA not as the wraparound services, but as the primary payment for the provider. So what we're working now, which we're working on, I'm not saying we've passed it, is that Medicaid would provide that. It really should be Medicaid doing the nuts and bolts of taking care of folks with mental health issues, and then the epi payment, if you will, that a little bit above, in Louisiana we'd call it the lagniappe, the extra dollars would be the wraparound services. So we're trying to take our Mental Health Reform Bill of 2016 and kind of get the original vision. That's one example of it. We want like hundreds of kids in this wraparound service provision. But you have to do that by doing, I think, the base payments through Medicaid. Other issues, there continues to be problems with access. Medicaid pays really poorly. So if Medicaid's your primary provider, it can be difficult to get outpatient services. By the way, one of the nice things, kind of the way you do payment, in the Evaldi response bill, the fact that we're embedding community behavioral health services in a federally qualified health center, the federally qualified health center gets an additional payment above base Medicaid. And so I think it's like 125%, something like that. So it gives you the better ability to pay your mental health provider, so that the mental health provider, isn't like losing money every patient they see, which is typical for Medicaid. They're doing better. And so there's kind of a strategy involved in this too.
For you personally, you're a physician, you're a former educator, you're now a U.S. Senator. Do lawmakers come to you? Do they ask you questions? And if so, what are they asking you about the mental health subject?
Yeah, so whether you're a physician or not, you probably get your credibility on Capitol Hill by how hard you work on an issue.
This is your issue.
Yeah, this is my issue. They want to know, is it cost effective? Are we doing something, or are we just throwing money at people who are not accomplishing anything?
And you tell them?
It's a mixed bag. Some things were clearly having an impact. Go back to the veterans going down, that veteran suicide rate. Is it plausible that we can do a program that can make a difference? So, for example, the way you would build a case, and this is what I just say over and over again, let's go back to veterans. Most veterans who commit suicide do so within 6 months of separation. So they leave the military, and within the next 6 months, they commit suicide.
Wow.
On average, sounds like a Monty Python skit. On average, the first appointment in the VA hospital after separation is 6 months later. Like, okay, let's just kind of leave you vulnerable out there for 6 months when we know that you have the maximal vulnerability. And I'm laughing not because it's funny, because it's so ironic. It is almost so tragic. In fact, it is tragic. So we just passed the Safer Veterans Act. I think I got that right. Safer Veterans Act, the title of it, in which the VA would attempt to contact somebody at least 3 times in those first 6 months by which after they separate. So they leave the military, they got 6 months, you're calling them. Is there an issue going on? Are you aware of this benefit? Oh, there is an issue. Can we beam you in? So I can go to my colleagues, and that was my bill and another we co-sponsored. I can go to my colleagues and say, this is a good piece of legislation, and this is why. Most suicides within the first 6 months, first appointment typically 6 months or later. We can make an intervention by phone. There's already the services to do it, and if we do it, we can plausibly further reduce veteran suicide. Now, if you make that case, you're going to have everybody supporting it.
So another community, you mentioned this earlier too, and we'll talk about those who are incarcerated, because that is a huge problem, both in the prisons, both in those facilities, and for those who do leave, often the revolving door because of mental health issues. How do you address that?
So again, you mentioned how do I approach things as a physician? One, you got to care. I mean, my gosh. Sometimes you just cry. On the other hand, you got to have facts. And so you want your doctor to bring all the knowledge that she or he has learned to an issue. So going to that particular issue, so I attempt to do that. I'm sure others do. I just mentioned it as a physician because this is my issue, as you said. If you talk to the sheriffs, they have a formulary for the drugs that they can provide. Now, if somebody has mental illness and they've gone through step therapy and we have found that certain drugs work and certain don't, but they enter into the jail and the drugs which have been empirically found to work are not on the formulary of the jail pharmacy, they will be put on a different drug even if that drug has already been shown not to work. Mm-hmm. And so they go into the jail, which I used to work in prisons for many years.
That had to be eye-opening.
What's that?
That had to be eye-opening.
Well, I worked in prisons, not jails. So a jail is typically less than 6 months incarceration. You get adjudicated, then you go to a prison. It was really eye-opening, by the way, working in a prison. You find that the unholy trinity of going to jail is no father figure for men, no father figure, illiteracy, and drugs.
Mm-hmm. That cycle.
So it just like one guy said, I got on drugs and I was never there for my kids, got thrown in jail, and now my son's in jail. There's poignancy there, right? Mm. So if we're going to, so we could talk a whole another thing about incarceration. But if you go to those in jail, they will enter into jail. The formulary is different. They're being placed on medications which empirically we know don't work for that person. Jail is already a hyperstimulated environment, and they will decompensate. And when they decompensate, they will act out in such a way that they may get in fights and extend their jail time. Now, the problem with this is that Medicaid does not, once somebody is put into jail, they lose their Medicaid benefits even before they're adjudicated. Even if they're ultimately adjudicated as not guilty, they have lost their Medicaid benefits once they go into jail. So, Steve, you ask, okay, as a physician, but as anybody else, you would think, well, this is nuts, no pun intended. Why don't we allow someone to continue on their Medicaid benefits even after they enter jail until they're adjudicated and found to be guilty, if everybody follows that. Now, we have something in the legislation, in our reauthorization through SAMHSA, that attempts to encourage that. And we're working on another package that would go through finance, which would basically, direct that states would continue Medicaid benefits for mental health services until somebody were adjudicated and found guilty. Just makes sense to me. Because what you don't want, even if somebody does okay in jail and then they get out and they have to reestablish their Medicaid coverage, they can have an interruption of their pharmacy benefit, even if the drugs they were on in prison worked for them. So if we're trying to interrupt this cycle of mental health and the kind of revolving door through the jail and people homeless, because most of them are mentally ill, are addicted, then we need to think systematically, analytically, where are things breaking down and where can public policy make a difference?
So closing thought in our remaining minute, we've gone over just a minute or so, but what should these folks be aware of? Where is the debate going? Where is the reauthorization? And what are your final thoughts?
My thoughts are that we will succeed if you are engaged. And for those folks who are watching online, there's no substitute for being engaged in a representative democracy. We have a reauthorization that's hopefully going to pass at the end of this year. We think it will. But if we're going to, for example, do the things on Medicaid that I discussed through finance, then whoever's watching, you need to contact your congresswoman, your congressman, your senator, and speak if you don't speak to them directly. Now, the nice thing about this is almost everybody is at least 2 degrees, only 2 degrees separated from someone who's both mentally ill, who happens to also know that congresswoman or that congressman. And so if you can just make the connection to bring it home to them, which may be their own family, then you can actually have an impact. And it is a mutual responsibility for the advocates, for those who have the privilege to represent, to come to good public policy, advocate for this good public policy.
And this issue is personal for Senator Bill Cassidy because?
I don't want to say that. I'll cry.
Senator, thank you very much.
Thank you.
Thank you.
Thank you.